The Ontario HIV Research Chair that I received really focuses on HIV prevention in kind of two different ways. On one hand, the goal of what we're doing is attempting to take people who are HIV negative and give them access to interventions that will keep them HIV negative, and at the same time deal with people who are HIV positive and actually give them access to treatments and other prevention technologies. So what the goal is to take basically HIV medications in both instances and say, if you're HIV negative, and we give you a low dose of HIV medication before or just after, sort of within 72 hours of a potential HIV exposure, we can actually reduce your risk of HIV acquisition, so of the person becoming HIV positive, by in excess of 96%. On the other side, with people who are already HIV positive, the goal is to say, how can we get you on medication in sort of a rapid way? And it's not a rapid way just so that we give people medications, but to give them an option of when they would like to start care, how they'd like to start care. And in doing so, not only will this benefit them in sort of their quality and quantity of life, but also just due to the sort of mechanism of action of the HIV medications, it's going to render them non-infectious. And so our goal is to study what are the factors, what are the parameters that are limiting or sort of making this discrepancy between self-report and actual uptake, and to test it in real life, and to say, can we implement these strategies? Can we do it? And can we get people to actually have access to this? Unique in that we're having nurses deliver the post-exposure medication, we're having nurses administer and initiate people onto pre-exposure prophylaxis, we're having them do the testing, the diagnosis, and the offering of HIV treatment. So it's unique in that we're doing it. It's also unique in how we're doing it, and that instead of it typically being provided through specialist physicians, we're having frontline community and public health nurses do the implementation of testing and research. We have groups that are most affected by HIV. We want to really target our interventions toward them, but also doing so with a stratification to say that just because you're a member of one of these groups, just because you're a gay man, right, or you're an Indigenous person, or you're from the Caribbean, it doesn't mean you are automatically at risk for HIV, but it's how do we stratify within these groups. And the chair has, we're building on our previous research to say we've done a fairly decent job of being able to stratify within the subgroups to identify risk. Now what do we do about it? We have the intervention, and sort of going back to what's unique with this focus is that we have nurses who are actively offering these interventions.